Welcome to St Mark's podcast. I'm your host, Peter MacDonald, one of the surgeons here. Now, St Mark's was founded in 1835 by Frederick Salmon, and originally it was named the Benevolent Dispensary for the Relief of the Poor afflicted with fistula and other diseases of the rectum. St Mark's Hospital remains the UK's only specialist bowel hospital and is dedicated to all aspects of bowel pathology. But today we discuss fistula, perhaps one of our home territories, an area of coloproctology inextricably associated with us as the Fistula Infirmary, as it was originally known. Our doctors have made numerous contributions to the fistula literature since 1835, including both in classification and management. Now tonight I welcome Mr. Phil Tozer, one of our current surgeons whose particular interest is anal fistula. Welcome, Phil.
Thanks, Peter. Delighted to be here.
Now this is a very informal chat, and we're going to talk about fistulas in various ways, but we thought we might go down, start first of all with the etiology. These are strange beasts, aren't they, these fistulas? Over the years we've talked about this and that, as whether they're infections or not, and so on. How do you see their etiology now?
Yeah, I think the true etiology of these things, these anal fistula, is poorly understood, and many of the listeners will recognise them being called cryptoglandular fistulas, but anyone who's come to any of our meetings in the past will recognise that we tend to use the term idiopathic rather than cryptoglandular directly. Nevertheless, the cryptoglandular hypothesis for the cause of these things remains the most prevalent and really probably still carries a great deal of weight. And this is the idea, first of all, developed by a number of famous names, but ultimately crystallised by Parkes, which considers that the infection arises in the anal glands that are arranged in the sphincteric space, maybe 6 or 10 of them arranged around at the level of the dentate line, opening up into the dentate line to deliver mucus to help lubricate the passage of stool through the anus. And the idea is that these become infected and set up as the seat of a chronic infection, which will then find its way out by one route or another, perhaps straight down the sphincteric space and out towards the skin, presenting as an sphincteric abscess, or else travelling through the external sphincter into the ischianal fossa, where they can fester for a lot longer, for several days rather than only 1 or 2, making the patient sicker with less pain by contrast with the sphincteric abscess, and then be drained out wide of the external sphincter and set up a transsphincteric fistula. And they can sometimes, as you know, travel in more weird and wonderful directions, including up the sphincteric space into the pararectal or supralevator space.
Right, we'll get on to classification and anatomy in a moment, and we'll just go over that again. But nobody really understands why I get it and you don't. There isn't a huge predominance of one part of the population or another. I mean, it's slightly commoner in men. It's about average age 40, if I remember. Maybe a bit commoner in diabetics, but is it? I mean, who gets it? Why does one person get these infections?
So it's certainly true that men are more common to get perianal abscesses, and men are more likely to get anal fistula. But interestingly, some of our work recently has suggested that if you get a perianal abscess and it is drained, and you're a woman, you're more likely to go on to have a fistula than if you're a man.
That's interesting indeed.
It is, and diabetics likewise, whilst one might expect them to be more likely to get perianal abscesses, progression from abscess to fistula seems to be less likely in the diabetic patient, and I suspect that's because diabetics are more likely to get perianal abscesses for other reasons, and it is a specific etiology which drives fistula creation, and that it's most likely that a fistula is in evolution in some perianal abscesses.
And there's no particular link with hidradenitis or any other skin conditions that we know of that,
No, certainly not for cryptoglandular fistula. There's a crossover of hidradenitis with Crohn's anal fistula, of course, and that the granulomatous diseases. But for the cryptoglandular fistula, that doesn't seem to be the case very clearly. And there are obviously a number of other suppurative conditions, but cryptoglandular fistula do seem to be this particular group on their own, probably driven by that anal gland.
Now, you mentioned the Parkes classification, or you mentioned Parkes earlier, one of the great St. Mark's surgeons who gave so much to us in the way he classified these, and we're still using his classification pretty well. And you had touched on intersphincteric and transsphincteric and so on. Have you got anything more to add to that?
Yeah, Parkes initially described the 4 different anal fistula: insphincteric, transsphincteric, suprasphincteric and extrasphincteric. And I think those last 2 are a lot more difficult to define. There are those who take the view that a true suprasphincteric fistula is pretty rare and may not even genuinely exist, and some people consider that many of the suprasphincteric fistulae are either actually simply high transsphincterics or might even be iatrogenic.
What about the ones that come down from the appendix or the diverticulitis? Are those suprasphincteric, are they going to be more likely to be like that?
So the extrasphincteric, those ones that I think we would call extrasphincteric fistulas, they're in an entirely separate etiology, and only if in the passage down through the ischoanal fossa from the pelvis, only if they then penetrate the sphincter complex and come into the anal canal do they really have anything in common with what we're talking about. And the extrasphincteric fistulas are managed by dealing with the organ that's caused the trouble, the appendix, as you say, or the Crohn's rectum, for example, or sigmoid diverticular disease, or gynae pathology, whatever it is. They have to be treated at the level of that pathology. Whereas the other 3, inter, trans and suprasphincteric fistulas, are thought, and the thing they have in common is that relation to the insphincteric gland.
Okay, and now another classification has been used over the years is low versus high. Is that useful?
I think it's very problematic, and it's used widely in the literature for people describing their own series of a particular technique, an advancement flap series, for example, and it's often very poorly defined within individual papers, heterogeneously across papers, and therefore of no use when we're trying to compare one to another. And I think high and low carries little value in that sense. It's really most useful, in my view, if it's going to determine what you can do to treat the patient. So the way we use high and low, or the way we encourage people to use high and low, I should say, is that high probably represents a fistula that you don't want to lay open, that's too high to lay open, whatever that may be.
Some people might say you don't want to lay open any of them, but because you lose control or you lose something if you lay open any muscle, but that's not terribly useful because we may have to lay fistulas open. I mean, are we talking about 50% of the sphincter complex, or are we talking about a fistula above the, close to or above the dentate line?
Well, I think that's difficult as well, because my decision not to lay open a particular fistula won't necessarily be terribly strong related to the height of the fistula itself. It might be as much about the patient and their bowel function or the presence of Crohn's disease or whatever. So the high-low dichotomy is poorly defined, badly used, and in general for those reasons not that helpful. But let's dig into it a little bit, and I think you're right, there are different ways to think about it. Some people argue that the lower third of the sphincter complex would represent the barrier between low and high fistulas, or 50%, as you mentioned earlier. Again, there's no consistent definition there, but those are both examples that people have used in the past in publications.
One of our predecessors, one of your predecessor perhaps more than mine, Professor Robin Phillips, also used to say it's not so much what you lay open as what you leave behind.
Quite right.
So measuring the residual muscle, if you can, very difficult thing to do, is more important than working out how much you've divided. What would you say about that?
Yeah, I'd agree with that entirely. Not least because he's probably listening. No,
well, you'll be lucky.
No, I'm sure he isn't. So let's say that one goes back to this idea of 50% of the anal sphincter. Well, in a man with a 4 centimetre anal canal, you could probably lay open a posterior fistula containing 50% and therefore leaving behind 50% of his muscle relatively happily, given some of the other things that I've mentioned about bowel habit and so on. But an anterior fistula in a woman with 1.5 centimetres of anal canal means you'd be leaving 7.5 millimetres behind. I think most of us would feel very uncomfortable about that.
Yes.
So as a definition, cutting a specific proportion of the muscle seems to me to be very unhelpful. Much more useful, perhaps, is defining how much muscle one needs in order to maintain continence. And you're right, that's exactly what Professor Phillips's view would be. If you're going to remove a kidney or even 1.5 kidneys from a patient, that still might be okay if they can survive on half a kidney. How much sphincter muscle does one need in order to maintain continence? And I think that's a very difficult question to answer.
One of my bad jokes, which I hope people remember, is that, of course, this is the only organ in the body which is superior in the male to the female. The rest, I think, we'll have to concede, hearts, brains, whatever, because we men do have much greater reserve if you're going to have to lay a fistula open than the female. What would you say?
Yeah, I think that's exactly right. And of course, that kind of generalisation is valuable because it helps us to talk about these things more broadly. But of course, it's necessary to talk in the specific, given the fistula in front of you. And some women, particularly perhaps prepartum women, will have quite a good anal canal. It may well suffer during the process of childbirth, but to start with, it may be pretty good. Whereas a man will usually have a pretty good sphincter, but might on occasion have one that's not so good for various reasons. So, yeah, I think that's broadly speaking true.
Before we go on to the third sort of idea of classification, which is simple versus complex, just to say to the listeners that these diagrams of this classification will be on our St. Mark's Twitter account for you to look at and study if you wish to. But what about simple versus complex? How does that help us?
Well, I think it helps in trying to determine a course of treatment for these different patients. So let me go into that in a bit of detail, and perhaps I'll start off by going back to the previous discussion, the high-low discussion, and talking about how one defines what height of muscle you need in order to maintain continence. And that will be based on things like pre-existing continence, pre-existing bowel disease, which might predispose now or in the future to a higher frequency looser stool that's more difficult to control, and so on. But in general, a patient with a normal bowel function and good bowel control, and without the risk of an occult sphincter injury from childbirth, for example, and so on, might be expected to do pretty well with 2 centimetres of external sphincter intact. And an understanding of whether the external or internal sphincter is likely to be divided, and the importance of those two in terms of maintaining continence, is important here. So the internal sphincter controls the fine control, your fine continence, and that's really about controlling wind and a little bit of mucus, which might otherwise leak out if the internal sphincter is deficient. Whereas the external sphincter is much more, as it's under voluntary control, about preventing urgency and being able to hold on when you get the feeling that you need to go. And of course there's a bit of crossover in both directions, but broadly speaking, it's in that way that one can think in more detail about how much sphincter needs to be left behind.
Because when I was young, I suppose I used to think about the external sphincter as the most important bit. But as I've grown up a little bit wiser, maybe, I realise it's not as simple as that, and the internal sphincter is equally important in many respects.
I think it's exactly right. And I think that also is related to how we think about the impact of continence impairment rather than continence on the patient. And if you're a guy who perhaps loses gas from time to time anyway, you may be less concerned about me telling you that will happen if I cure your fistula with a fistulotomy. But a professional in a meeting, perhaps women more than men, might have a much greater anxiety, quite rightly, about being unable to control wind and the impact that would have on their lives. And so the idea that only frank fecal incontinence is important has rightly gone to the wayside. So the simple complex question that you asked me, I'll now finally come to address, and I think that's important partly because of what we've just been discussing, and the complex fistula is more likely to involve more aspects of different parts of the muscle, and that's really what defines complexity for me. So a nice straight transsphincteric fistula that's not too high I'd consider simple, as I would with an intersphincteric or a subcutaneous fistula. But anything that's higher, anything that branches, has extensions, horseshoes around, or has cavities associated, these are all going to be more complex fistulas, as would be anything associated with an underlying disease like Crohn's or previous radiotherapy treatment, or any connection to the vagina or vulva. And I think that really is valuable, because a simple fistula might then be one that we could consider laying open in a patient with normal bowel function and good control and so on, whereas a more complex one might need some kind of treatment prior to either fistulotomy or a sphincter preserving procedure.
You're suggesting that you might want to drain the bulk of the sepsis before you attempt to cure it in whichever way you're going to. It's always said that a complex fistula will resolve if you get rid of the simple component, i.e. if a transsphincteric fistula is probably the cause of the thing, like a horseshoe posteriorly where the transsphincteric fistula is in the midline posteriorly. If you lay that open properly, then the complex side of it should resolve. Would you agree with that?
Yeah, I think that's probably broadly true, but it's certainly not always true. And as you said, that's about laying the fistula open. If, in fact, what you're aiming for is a sphincter preserving procedure because it's too high to lay open, or it's too high for that patient to consider you laying it open because they don't want any of the risk of continence impairment that we've discussed, then it will be important to rationalise that fistula. I think this is a really useful concept, this idea of taking something complex and distilling it down so that it's simple, which means that it can either be laid open if possible, managed more effectively palliatively with a luceton, for example, or might then be amenable to treatment by one of the sphincter preserving procedures, which I guess we'll talk about later on, giving it a chance to be healed but without running the risk of continence impairment.
Let's move on to the management of acute sepsis, because a lot of these fistulas present with a perineal abscess, don't they, to the emergency department, often to a surgeon who's got no interest in fistulas, as any wise man or woman is probably it's probably a reasonable position to take.
Yes.
But for you and I, we don't have that option. We are thinking of the fistula and the long term. How do you manage the acute perineal abscess in the presence of a fistula? Or perhaps you don't even know it's a fistula at that point, but how would you advise it's managed?
I think this is a really important question, and it's one which I think is often viewed in the wrong way, which has led many esteemed individuals and institutions to get the wrong end of the stick here, in my view. So a patient will present with an acute abscess, an acute perianal abscess, and it will often be difficult to discern whether that's intersphincteric or ischioanal or and so on very clearly in the emergency room. Although it will usually become apparent with careful examination by a colorectal surgeon, and certainly in theatre. But the patient will present, and the first decisions are about when the drainage should take place. And this will be something that's familiar to all of the surgical registrars listening, the idea of trying to get an abscess drained overnight. They are rarely seen as the most important problem, and rarely are they the most important problem, except to the patient who has them, of course, when they're excruciatingly painful in many cases and really should be drained as quickly as possible. But there are situations where the patient should undergo urgent drainage despite the lateness of the hour. And those are situations like the immunosuppressed patient, for example, with diabetes, evidence of spreading cellulitis, any feature which might suggest a predisposition towards a necrotizing infection.
And we do see that from time to time.
Absolutely.
And it must not be forgotten that these can be, well, probably they're the most potent cause of necrotizing fasciitis as a single disease entity. And, we see a lot of perineal necrotizing fasciitis, so that has to be borne in mind sometimes.
Absolutely. I think it's always important to remember that when you're looking at an abscess patient, it's very rare that they will have a necrotizing soft tissue infection, but if they do, you cannot miss it. It's crucial to pick that up and to treat them.
So you found this abscess. We're going to treat it tonight or tomorrow morning if we can. If we think it's going to burst very shortly, like I saw one on Friday, and I said I think it's going to burst tonight. I don't need to do this tonight. It was just about to. Sure enough, it did burst overnight. So I'm going to do it in an elective way on Tuesday and find the fistula at the same time probably and treat it if I can primarily. what would you be doing? Just draining it through a decent sized hole? Because quite often we find the young registrar doesn't make a decent enough hole, and we're often having to go back a week later. What would you say to that?
I think that's exactly right. I think people worry about making the hole too big when in fact they should be worrying about making it too small. And it's hard to cause too much harm in this situation if all you're doing is draining the abscess. Of course, it's useful to bear in mind where the sphincter muscle is, and incisions are often then placed around the circumference of the anus over the abscess, rather than running outwards in a radial fashion from the anus itself, to reduce the risk of muscle injury. But the key is to get into the cavity and to de-roof it widely. Clean it out by all means. Scrape it with a curette if you wish, but really, as long as it's well de-roofed, then it will do well.
Because it was the founder of this hospital, Frederick Salmon, who emphasised the need for drainage around the anal canal. In his, I think he was talking about hemorrhoids hemorrhoidectomy, but nowhere is it more important than this condition. As long as you're getting good drainage, it doesn't really matter the shape of the hole you've made, but you've got to make it big enough to get drainage.
Yeah, I think that's exactly right. And phrases like big enough, which we've both used, are probably making some of the people listening tear their hair out. So what does big enough mean? I guess it depends a little bit on the size of the cavity. The key is that it has to be able to drain until it heals from the inside out without the need for packing. That's my criteria for big enough. And that almost always means I can get my thumb into it, and it might well mean that I can get something more than my thumb into it.
You use the word packing because I'm not a great lover of this word.
No.
I mean, if you make a big enough hole, you don't need to pack. Patients hate the process of having wounds packed. It shouldn't really be necessary if you've made a good exit arrangement for the pus.
I think that's exactly right. There is very rarely a good reason to pack, in my view, and there is no one actually in the world, apart from the people who sell packing materials, who likes packing. Patients don't like it, surgeons don't like it, district nurses hate doing it, everyone dislikes it, and it's a very limited value, I suspect. You'll know that there's a trial going on at the moment which I hope will demonstrate just that. It'll have to demonstrate the opposite pretty strongly if it's going to get us to change our practice here. We pack very rarely.
Yeah. Now you've drained the abscess. That's all been sorted. Now, many patients, of course, don't present with an abscess. They present with discharge and bleeding and occasional pain and a lump. And you make a diagnosis of a fistula. This one's not a simple one that I'm painting the picture of. It's a deep one. I mean, I think simple ones, very low ones, submucosal, low intersphincteric, or even fissure fistulas, which we see from time to time, they don't need any fancy imaging. But for those ones where you're beginning to scratch your head wondering, is this a difficult fistula? Is this extensive? What imaging are you going to do, and how would you advise people?
So let me answer that question by talking about the process that I go through when I see one of these guys to start off with. So if I see someone with a first-time perianal abscess, I will warn them that there is a risk that they will develop a fistula, and that I'll be seeing them in clinic shortly in order to look for that. In the past, I would have suggested to a patient with a primary abscess that was likely to occur in about a third of cases. I think the newest evidence that we've put out correctly identifies that the risk of fistula in patients without inflammatory bowel disease is much lower than that. It's probably around 1 in 6. And that, I think, is good news for patients with perianal abscesses. So with a primary perianal abscess, I do nothing. I just wait. The question is always asked whether you should treat a fistula if the internal opening is found at the time of abscess drainage. And the Cochrane review on this and the ACP-GBI emergency surgery statement most recently put out suggests that you should, because it reduces the risk of fistula, quotes, recurrence without having a significant impact on continence impairment. Now, this is where I was suggesting earlier that I think people have got the wrong end of the stick, and I do not share that view. It tends to be that surgeons argue that the reason for avoiding fistula treatment at the time of abscess drainage is that it's undertaken by junior surgeons who perhaps aren't so familiar with dealing with inflamed tissues and understanding fistulas quite so well. And I think that's true, but it's not the main reason. there's really good evidence from randomized controlled trials that when you come across an abscess with an internal opening, if you don't treat the fistula at the time and you leave it alone, a half of those patients will never return with a fistula. And if you undertake fistulotomy, then you give them the continence impairment risk that half of them never needed to see. And if you place a seat on, then you condemn all of them to a fistula and whatever treatment is required thereafter. And so with a primary abscess, I would leave the internal opening alone. Just drain it. Do nothing else.
That's an important lesson to learn. So we've established that for the perineal abscess, we're going to drain it. Now we've got a patient with a fistula in front of you, probably without an abscess, and you think it's going to be complicated or it's rather deeper than your finger's telling you. First of all, you've got the finger assessment in clinic, which if it's not too painful is really very useful, but sometimes it is very painful.
Yeah, I think that's right. So if I've got a fistula, which I think is simple, and I can feel the internal and external openings, and I can trace the tract almost entirely between one and the other, and I can find no evidence of induration or complexity around clinically, then I won't undertake an MRI scan. But under any other circumstance I will, and of course that, for me at least, is the majority of patients. So if there's any suggestion of induration away from the primary tract, if the primary tract runs away from the skin and is therefore too difficult, too deep for me to palpate, if there's more than one opening, if I'm thinking about a sphincter preserving procedure, under any of those circumstances, I will undertake an MRI, because if I want to consider a sphincter preserving procedure, it will fail if I haven't first rationalised the tract. And if I want to consider fistulotomy and the tract runs away and I don't know the height at which it crosses the external sphincter, then I'm exposing the patient to real risk in a way that I don't need to, because I could define that beforehand by getting a scan.
You went straight for an MRI, not an EUA or an ultrasound.
So EUA certainly gives you more information than examination in clinic, but I think it answers, or rather it fails to answer similar questions, and particularly I'm thinking about the height at which the fistula crosses the external sphincter, which I think can't be defined very easily in clinic or at EUA without an incision, and complexity in the intersphincteric space or out in the ischoanal fossa. I think those are much harder to define clearly. I think we can argue that we know that they are there, but defining exactly how big they are, which direction they go in and so on is much more difficult clinically and at EUA. So I think an EUA is very useful, and there's good evidence that EUA is more useful than clinical examination alone, but that, just like MRI and endoanal ultrasound on its own, it won't give the full picture all of the time. And
but just like surgeons, you need radiologists who can do it well with machines that are the right caliber, with the right button switched on to get you the answer. So, this is very important. We talk about, surgeons being specialised between general surgeons and coloproctologists and breast surgeons and so on. We don't talk about radiologists so often that way, although they are becoming very specialised, but you need a damn good one to give you the information, do you not?
Absolutely. And we're lucky here, and many people are, to have specific GI radiologists. But even within a GI radiologist team, there might be one or two people who have a particular interest in fistula MRIs, and they can be very, very challenging to read, as you know. And I spend a lot of my time sitting in a dark room with one or other of our radiologists, picking through scans both before and after surgery, really trying to understand what they're showing us. It's extremely valuable. The endoanal ultrasound question is a good one. There is evidence that an endoanal ultrasound is just as good as an MRI in defining the fistula. I think there are one or two things it's better and worse at. Endoanal ultrasound is not so good at identifying fistulas the further away from the anal canal we are. And their main benefits, in my view, are in identifying the location of the internal opening, which I don't usually need help with. That's usually apparent clinically, and in defining the quality of the sphincter complex, at least structurally, if not functionally. So I think endoanal ultrasound is fine for those people who use it, but my preference is for an MRI, which we can then use and review time and time again over the course of treatment, and can also show to patients, which I think is very valuable.
Okay, so we've now got the information, you decided to treat it. What are your options here for for treating this fistula?
So there's always three options. This is how I present it to patients, and I think it's true. There are always three options for managing a fistula. The first should always, in my view, be consideration of fistulotomy, because that's the surefire way of curing the fistula. It will almost always cure the fistula. Our data, and that of several others, is that it will work 95 or more % of the time, although the Fiat data didn't really support that.
The Fiat data remind
Fistula
us.
and ANO trial. So it was the trial looking at the plug run by David Jane and others, and it was really designed to look at transsphincteric fistulas to see what the true efficacy of the plug was. They haven't reported yet in the literature, but we've heard talks from them in the last couple of ACPGI meetings, and the fistulotomy success rate, healing of fistulas, was probably only up around 75%, I think, which is not what I would expect. And I would tell patients I would expect to cure a fistula almost all of the time. And I think that's correct. That's certainly what we've seen in series we've published here before. So I'd expect their fistula to be healed, but there is a cost to that high success rate, and that cost is the risk of continence impairment. And I would go into detail with them about what I thought that risk was. And if either it is too high for me to contemplate, by which I mean greater than a risk of difficulty with controlling wind and perhaps marking of the underwear, or if it is only that risk but the patient doesn't want it, then we move on to the next two options.
Okay, and now we're going to discuss the next options, the other surgical options other than laying open, in our next podcast. So, Phil Tozer, thank you very much for at least doing half the job. And for those listeners who want to learn more about this very complex subject, which is always the topic of greatest interest in our courses here at St. Mark's and our Frontiers meeting, which we have every year, it's always fistula which tops the bill. You may have to listen to podcast number 2 in a short while. Thank you very much.